Hello, this is Dr. Wendy Wood with a recorded lecture on wound examination and treatment. And this again is from the text previously used from Betsy Myers with acknowledgments to Dr. Kathy Lesnick. First of all, looking at examining the patient, we want to do a thorough history and look at general demographics, age, race, gender, education. This could be helpful because patient education is going to be a big part of the treatment. And also looking at other factors in terms of age. Are there factors that relate to possible delayed healing? We want to look at lifestyle and functional status, mobility, vocation, social support, continence, all those kind of things. And past and current medical history, systems review, all of these things are very important as we've talked about diabetes, coronary arteries, peripheral vascular disease, obesity, CAD, peripheral neuropathy. All of these go hand in hand with looking at wounds very closely. We also want to look at the past and current wound history and what has been tried so far, what's worked and what hasn't worked. So here's some sample medical history looking at high blood pressure, diabetes, heart disease, cancer, all of these things. We want to look also at, are they allergic to anything? Because we want to know if we should avoid using latex or adhesive, sulfa. All of these kind of things are very important. We want to know if the patient has smoked, how many years, how many packs a day, do they drink alcohol, number of drinks per day, and we want to know any drugs that they're taking. All of these things we've talked about, especially in terms of steroids affecting the patient. We should get lab values. This is going to help. Total blood count, hematocrit, hemoglobin, total white blood cell count, platelet, lymphocytes, serum albumin. These are all very important for wound healing. So looking closely at these is very important. And each of these, if they're either low or high, especially if they're low, can let you know if there's a problem. A few of these, we want to look at if they're high. So this is a nice list looking at the possible significance of abnormal values. This is again where it is a process of a team approach. These are some more blood values to look at. Prealbumin, transferrin, serum transferrin, blood glucose, urine glucose, BUN, and creatinine. So I'll let you go back and take a closer look at these and pause if you want. But lab values are very important, and this is just a preliminary list. Some sample wound questions are: you want to know when and how the wound began. Have there been any tests that have been performed? Any current or prior medications for the wound? Wound-related pain? What is currently being done to the wound? What was tried in the past? Is the wound improving, staying the same, getting worse? Systems review. We've talked about we want to identify referral needs, identify risk factors, identify signs and symptoms consistent with certain disease processes, and determine educational needs. We want to look at cardiovascular function, pulmonary function, because all of these are important for wound healing. Heart rate, blood pressure, respiratory rate, edema, pulse ox. We want to look at the GI system. What is the nutritional intake? Is the patient taking any supplements? Are there any continence issues? What's the person's BMI? We want to look at overall at the integumentary system. Besides the wound, we want to look at the rest of the skin. If there are any problems that might give us a clue as to why the wound isn't healing. We want to look at peripheral pulses. Remember, a grading is 0 to 3 plus. 0, 1 would be absent or diminished. Capillary refill, test of dependency of the Ruber test, and the ABI, or the arterial blood. Oh, I'm getting kind of, can't remember exactly what that is. Arterial brachial index. So we want to look at that comparison. We talked about that in a previous lecture. Skin integrity, we want to look at, is there an impairment with light touch? We want to look at testing with the gold standard, which is the Symes-Weinstein monofilaments, and those are depicted here. Remember, the number 5.08 monofilament is 10 grams. You need 10 grams or more for protective sensation. If not, you're at risk for wounds. So we want to look at the integumentary integrity and wound characteristics. What is the location? You want to use anatomically correct terminology, and you want to look at the dominant side and body surface of the lesion. You want to document the side and body surface of the lesion, and document in relation to anatomical landmarks. We'll get into that more in depth. We want to look at the wound size, 2 approaches. We could look at the greatest length times the greatest width, or we could use a clock method, and we're going to look at that. In the clock method, the head is 12 and the toes are 6. There are various methods for wound measurement. We could do a direct measurement, tracing, photography, or volumetric measurements, or the percent of total body surface area. Here's a clock method. Remember, the head is 12 and the toes are 6. So this will allows you to see and document so the other person can follow up where things are. And this is a direct measurement. You could use a stick. You're measuring the wound depth. This is with a calibrated measuring stick. And here you have to also see that you need to document if there's eschar, because that doesn't really give you a real picture of how deep the wound is. Once the wound is removed, you can really see what the true depth is. So when you do document that if there is eschar, if you're taking a measurement. So here we have unable to determine actual wound depth secondary to eschar, and they give a measurement. Wound tracings, you're going to use 2-layered transparent film. It's more accurate representation of the wound size, and it allows for future comparisons, but it might be difficult to visualize wound perimeter through the transparency. So here's a wound tracing, and then again another tracing 2 weeks later, and you can really see the change. However, sometimes you have tunneling, which can create problems. So here's another wound tracing using graph paper. Back to the graph paper, what you do is you count the boxes. So this can be helpful. Integumentary integrity, wound characteristics. You could take a photograph. We have really good digital photography now, and you don't have to contact the patient's wound, so that's good, and it really does give a nice look at the peri-wound wound bed and characteristics. But the camera angle and distance can really influence the image size, and it can be manipulated. So this is a nice adjunct perhaps to a tracing. You want to look at the wound size compared to the total body area, surface area. This is another way to look at it. Do this a lot with burns. You want to look at the wound edges, Are they distinct? What is the thickness? What is the color? Are they attached to the base of the wound? Is there evidence of epithelialization, scarring, and pigment changes? These are some pictures of wound edges, and as you can see, these aren't really attached very well. So that's a very important consideration. That's going to cause a problem in healing. Look at the wound edges. Are they diffused? Are they diffuse? Are they calloused? So we see a couple calloused ones here, and this is a diffuse one. Is there tunneling? Tunneling is common in deep wounds, and you use a clock terms to identify the position of the tunneling. It's common in patients with neuropathic ulcerations and surgical wounds. Sinus tract is a term used interchangeably with tunneling. So there could be undermining. Use clock terms to identify the position. Again, it's common in patients with pressure or neuropathic ulcerations. So here's an example of wound tunneling. Here's a cross-sectional schematic. And here it's noted the wound tunnels 1.9 centimeters at 3 o'clock position. You can use a cross-sectional schematic of a wound with undermining. You need to determine the extent of undermining as well as the position. So here, undermining 1.2 centimeters from 9 o'clock to 1 o'clock. I'm going to look at the wound bed. Is it granulated tissue? Is it regular, beefy, granular? Pale as poor? Is there necrotic tissue? Meaning, is it slough that's stringy and fibrous or slippery? Eschar that's soft or hard, dark, black, or dead? Other structures within the wound bed: fascia, muscle, tendon, joint capsule, bone, foreign bodies, or debris. You need to document all of that. Here's a patient with a venous ulcer at the medial malleolus. And here's a nice example of documentation, really giving an idea of how much slough and granulation tissue. And then also even looking at the surrounding area. Here we have, there is extensive hemosiderin deposition, posterior, superior, and anterior to the ulcer. Here's slough, a yellow stringy on the left versus eschar, which is dry and black. So here's a documentation of different types of wound drainage and the description. So this can be very helpful. You want to document the type, the color, the consistency, and the amount. So here's some very helpful terms for that and what the interpretation could be. Even down to a specific organism. Blue-green could be probable Pseudomonas infection. So here's a desiccated wound bed. So that's, you could see the edges are separated. You want to look at the wound characteristics. Is there an odor? If there is odor, it could indicate infection. Necrotic tissue often has an odor, and all wounds are contaminated, but you do want to note if there's any odor. Look at the peri-wound area. What's the color? Normal skin. You need to be mindful of the patient's race. That's very important. And then note that, so, depending on the color, it might kind of be consistent with their race. Is it pale and blue? Is there hyperpigmentation? Are there epithelial appendages? What is the hair and nail growth like? Here is some ways to document the peri-wound area. You want to look at edema. Is it pitting or non-pitting? And use the scale. Is there induration? So in other words, accumulation of fluid. It's kind of like a hardness. So here is a classification of pitting edema, and in terms of time and then in terms of the indentation. Those are both important to note and grade. So you need to organize signs and symptoms into categories to determine the prognosis, plan of care, and interventions, the wound etiology, any comorbidities, and any nutritional concerns. Oops. So with physical therapy, we're going to work on the wound, but we also, again, really need to be cognizant of needs for a referral. A clean wound is a happy wound. So if the wound is not clean, if there's dead tissue, it needs to be debrided in some manner. So this is looking at different wounds and before and after debridement. Very important to look at. Here we see peri-wound callousing, and this allows for more of a connection between the epidermis and dermis. And this gives you a nice idea of how we're going to progress the wound to help it heal. So purposes of debridement, we need to decrease bacterial concentration within the wound bed and the risk of infection. We need to increase the effectiveness of topical antimicrobials and improve the bactericidal activity of leukocytes. We want to shorten the inflammatory phase of wound healing. We want to decrease the energy required by the body for wound healing. We want to eliminate the physical barrier to wound healing, such as necrotic tissues, and we want to decrease the wound odor. So you want to estimate the percent of viable from non-viable tissue and decide whether or not you should debride the wound. A complicated wound like this might require a consult. Very difficult. Sometimes you want to assure that you're not going to be causing any damage. This does appear to have a lot of dead tissue. So general contraindications for debridement: red or granular wounds. Those are wounds that are beginning to heal. Heal ulcers with eschar if they do not have edema, erythema, or drainage. Wounds that require surgical debridement, electrical burns prior to physician assessment, or arterial insufficiency wounds with a low ABI. Remember, that's the arterial brachial index. Methods of debridement: there's selective debridement to remove only non-viable tissue. So that would be sharp, autolytic, enzymatic, or biological. Non-selective, that's going to remove healthy tissue as well. So we have to be, careful of those things. Sometimes that's our only choice, but we'll be looking at a few different things. Mechanical would be hydrotherapies of different kinds: whirlpool, pulsatile lavage, irrigation, wet to dry dressings. Chemical through cytotoxic agents or surgical. Okay, sharp debridement, you're going to use a forceps, scissors, or scalpel. It's fastest, it's most aggressive form of debridement available to a PT, and it is under our scope of practice. Not every state's scope of practice. Pay attention to that, though. Sharp debridement indications are large amounts of necrosis, callus, advancing cellulitis, sepsis, or eschar. It could be used on wounds with any amount of necrotic tissue or chronic wounds. Sharp debridement contraindications: when the area cannot be adequately visualized or the material to be debrided is unidentified, lack of clinician competency, or with ischemic ulcers with low ABIs. Caution: immunosuppressed patients or patients with thrombocytopenic issues, or patients on anticoagulants. Got to be very careful because you could end up with a lot of bleeding patients on anticoagulants. So you're going to use a forceps to lift the devitalized tissue and hold the scissors flush with the patient to avoid piercing them. When debriding with the scalpel, you're going to hold the blade level with the tissue to be breded to avoid cutting into deeper, healthy tissues. With eschar, you can do cross-hatching, and that is going to help to increase the wound surface area. Here we're looking at a wound here. And this is the before, this is the after, that was the before. You can see how nicely things have been removed. It's going to help the wound heal. Autolytic debridement, that is where endogenous enzymes are used to digest necrotic tissue with a moisture-retentive dressing. It's the least invasive and the least painful method. It's easy to teach, requires minimal time to perform, and requires time for debridement to occur. Does not allow for frequent wound visualization, so that's a problem. With autolytic debridement, you're going to place a cover. Again, this is everything I just mentioned. You can see if the wound's covered, we're not going to be able to visualize it. Some of the indications: all wounds with necrotic tissue, or patients who can't tolerate other forms of debridement like sharp debridement. It's commonly used in long-term care settings or at home. Contraindications would be infected or deep cavity wounds, or wounds that require sharp or surgical debridement. The procedure is you're going to cross-hatch the eschar and put on a moisture-retentive dressing 2 centimeters larger than the wound, and you want to keep it on 72 to 96 hours and protect the peri-wound area. Enzymatic debridement, Santilla is an example. This is kind of a type of chemical debridement. It is a form of selective debridement. It does require a physician prescription. And here it is, collagenase. It's the only enzyme currently approved by the FDA, very expensive, $205 per tube. With enzymatic debridement, you want to follow the manufacturer's guidelines. You need a physician's prescription. You're going to do crosshatch on the eschar. You want a moist environment, observe for infection, and use topical antimicrobial therapy as needed. Mechanical debridement. So this is a use of force to remove devitalized tissue, foreign material, and debris. This is non-selective. So a few examples of this would be the wet to dry pulsatile lavage. If anybody doesn't know what that is, it's kind of a handheld device. I've actually done this on patients that have been in bed in the hospital, and you cover the area and it's just kind of squirting, kind of flushing the area out. So it's much gentler than whirlpool. You could do scrubbing, whirlpool, wound cleansing, hydrogen peroxide. With hydrogen peroxide, remember, you're going to kill both vital and non-vital tissue. You could also do wound irrigation, which pulsatile lavage is kind of an example of that. You need to be careful with the PSI, or pounds per pressure per square inch. Anything greater than 15 is going to damage healthy tissues. So 8 to 12 is usually adequate. Less than 4 is not effective. So again, low would be 1 to 15. High is 35 to 70. I'm sorry. Whirlpool jet in the area, it would be 100 plus PSIs. That's where you have to be really careful. Wet to dry, you're going to apply saline moistened gauze, allow to dry, and then you're going to tear away the dressing. It was prior, in the past, that was the standard of care. Now we have a lot better options. It's only indicated for wounds with a devitalized wound bed. This is a debridement technique. It's not appropriate for dressings. Wound scrubbing. This is with high porosity sponge, brush, or gauze, water, or saline. It's contraindicated for granulating wounds because you're going to take out devitalized tissue. It's best used for highly contaminated superficial wounds. Biological debridement, kind of gross, but it's actually been found to be effective. It's maggot therapy. And these maggots, of course, are sterile and they're unaffected by antibiotics, and it's faster than autolytic and enzymatic debridement. It may decrease the odor and exudate, and it may increase granulation and the epithelialization, and it is actually FDA approved. And that is for necrotic tissue. There's many, many different wound dressings, wound cleanses, normal saline. Again, we want to cleanse with 14 to 15 psi to remove bacteria. Antiseptics and disinfectants should be only used for 3 days. For home use, actually, contact lens solution is another alternative. Moist wound healing. Moist wounds heal 5 times faster. So it's going to facilitate all 3 phases of healing. It's going to trap endogenous enzymes to facilitate autolytic debridement and preserve endogenous growth factors. It reduces pain experience also, and it results in a more cosmetically appealing scar. We don't want wounds to be too moist because then they get macerated and we have damage and more chance of infection. We don't want them to be too dry or we're going to get a lack of enzymes and growth factors. So clinical decision making for wet wounds, we need to drain them, absorb the moisture, protect the surrounding area from maceration. Non-draining, we need to provide moisture, prevent evaporative fluid loss, and add skin moisture. Functions of wound dressings. Primary dressings are in direct contact with the wound and they fill the open space and they shouldn't be too tight. Secondary dressings go over the primary dressings and they can provide protection, cushioning, absorption, and occlusion. Some clinical decision makings with wound infection, we want to avoid occlusive dressings, rebandage daily, and we want to use good dressing options, gauze, alginate, semi-permeable foam. We want to look at the availability of dressings, cost needs to be considered, and of course, wound location. Wounds with dead space, filling materials should be confined to the wound bed. Use sterile instruments and packing material. Use alginate tipped applicators and leave a wick. So you want to leave an area outside so it can be pulled out. Moisture retentive dressings, those are synthetic or organic dressings. We want to maintain that moist environment. We want to occlude the area if needed to trap the wound fluid. We want a low moisture vapor transmission rate. That facilitates autolytic debridement, decreases pain, and allows for faster healing. There are various moisture retentive dressings. These help lower the infection rate, and it's non-traumatic removal from the wound bed. They can be water resistant, allowing the patient to bathe, wash dishes, or swim. And they could be adhesive or non-adhesive. So we have everything from occlusive to non-occlusive. You might want to come later to look at this. So that's really going to help you in deciding, based on the wound, what do you need. Gauze dressings, woven cotton, or you can have non-woven gauze. This is highly permeable, relatively non-occlusive. You can have a finer weave. It's a primary or secondary dressing, and it's inexpensive for one-time or short-term use. These are some examples of gauze products. Semi-permeable film, those are thin sheets. and they're permeable to water or oxygen or carbon dioxide, but impermeable to bacteria. They're little absorptive and insulating, and they allow for nice visualization. They're highly elastic and comfortable. So this is another example. Hydrogels are 80 to 90% glycerin based, and these are like gel sheets, and they bring moisture to dry wounds. But they absorb a minimal amount of fluid, but they are permeable to gas and water, and they may decrease pain. And they're almost non-adhesive, so you need a secondary dressing over them. Semi-permeable foams, they are usually of polyurethane foam, and they're permeable to gas but not to bacteria. They provide thermal insulation and cushioning. They apply easily and remove easily, and you could get them adhesive or non-adhesive. Hydrocolloids contain hydrophilic colloidal particles. They absorb fluid slowly. They swell into like a gel. So they're impermeable to water, oxygen, and bacteria. Duoderm is an example. That's an effective barrier against urine, stool, and MRSA or hepatitis B or HIV-1 and Pseudomonas. Then there are alginates of different varieties. Those are from seaweed, and they react with serum and wound exudate to form a hydrophilic gel to provide a moist wound environment. They can actually absorb 20 times their weight, but they do need a secondary dressing. Composite are multi-layer dressings, and they usually have 3 layers. An inner layer that's not adherent, prevents trauma to the wound bed, a middle layer that absorbs moisture, and an outer layer that's a bacterial barrier, usually a semi-permeable film. Collagen dressings are like sheets, ropes, and pads, gel, paste, powder, or particles. You want to consider these for non-healing category stage 3 or 4 pressure ulcers. And they're contraindicated if the patient's sensitive to collagen, but they are used often for partial or full thickness wounds. Skin sealants and moisture barriers. Here's an example. The future of wound management. Always things are coming out. Cytokines, interleukins, colony-stimulating factors, growth-promoting substances that enhance the cell size. In humans, wounds are treated with growth factors to improve wound healing. Black box warning is a 5 times greater chance of cancer. 3 tubes are only $600 per tube, so expensive but not out of range. So if you think about it, if they're increasing growth, they could stimulate cancer. There's a lot of evidence for use of these in neuropathic ulcers only at this time. So more evidence needs to be done. Thank you.